How's it going, everyone? Today we are going to be talking about the respiratory system. So in this video, I'm going to introduce our lungs and our air pathways, and then discuss how we are able to ventilate, which is the mechanical process of getting air in and out of our bodies. And then in the next video, we'll talk a little bit more about lung volumes and capacities, the different measurements we use in order to assess lung health. And then we'll also discuss how different gases such as oxygen and CO2 are transported throughout the respiratory and cardiovascular system. Respiration or breathing is going to allow us to take in quantities of O2 that are necessary for metabolism and also exhale or expire out carbon dioxide that we have produced during metabolism. And so this process of inspiring and expiring air, inhaling and exhaling, that's called ventilation. That's what we're going to speak about mostly today. But those gases, they travel throughout our bloodstream. And when we take in O2, that O2 is going to bind to those red blood cells within our blood and then be transported all throughout the body. And then once that blood that is more oxygenated reaches cells undergoing metabolism, that O2 is going to be dumped off at those cells, and then as a byproduct of metabolism is CO2. And so that CO2 again gets transferred through this venous blood in higher concentrations to the lungs, where it will then enter the alveoli and then we expire it out. So this gas exchange we'll talk more about in the next video, but today let's focus on that ventilation process. Before I get into ventilation, I do want to introduce the respiratory epithelium, which is a group of cells that is going to help clean out our air pathways from dust and debris and different pathogens, different microorganisms, different particles that we don't want entering our air pathway. So this mucociliary escalator is basically the process of these hair-like projections called cilia and mucus trapping these different particles, this different dust, these different microbes, and basically trying to expel it out of our air pathways. And what that's going to do is that mucus makes its way up through our trachea, is that we're going to either spit it out or we're going to swallow it. And this is just a protective mechanism, again, just to get rid of different particles and different microorganisms that may potentially bring damage to our air pathways. We are going to conduct air through our nose and our mouth from the atmosphere, and that air is going to start to enter the back of our mouth and this little area here called the pharynx. And so once that air makes its way through the pharynx, it will then head towards the larynx. And this is where ultimately air is going to either go down its pathway through the trachea, or food and liquid will go down its pathway through the esophagus. And covering the trachea is what's called the epiglottis, and basically that prevents from when we are eating and chewing, that prevents any food or liquid particles from getting into our air pathways. But basically air will then make its way down our trachea and then separate into the primary bronchi and then enter our lungs. We have two different zones of our respiratory system: the conducting zone, which consists of the nose, the pharynx, the larynx, the trachea, the bronchi, the bronchioles. This area of the respiratory tract is going to prepare the air, and that means warm and humidify the air to prevent damage from the cells within our lungs. But where the exchange of O2 and CO2 is going to take place, that is called the respiratory zone. Here we can see the breakdown of those two zones. So from the trachea, we have the primary bronchi, and then those will diverge into smaller bronchi, eventually going down to even smaller air pathways called the bronchioles. And then it'll enter that respiratory zone. where it will begin in what's called the respiratory bronchioles, and then the site of actual O2 and CO2 exchange is going to take place in these alveolar ducts, which contain these alveolar sacs, where capillaries will surround these alveoli, and that's how we get O2 to be delivered from the lungs to the bloodstream, and how we get CO2 to go from the blood into the lungs and then eventually exhaled out. Air coming in from the trachea are going to enter this left and right bronchi, and then that air is officially entered our lungs, which are these two cone-shaped structures here that are located within our rib cage, within our thoracic cavity. And lining the lungs are membranes, and the inner membrane is going to be called the visceral pleura, and the outer membrane is going to be called the parietal pleura. And when we talk a little bit more about ventilation here in a second, we're going to see why the two membranes are so important to that breathing process. And so, our lungs are going to contain most of those air pathways, most of the components of the respiratory tract, and the final destination of air will be in those alveoli, which are these little sacs of tissue and cells located all throughout the lungs. Air is going to travel all throughout the respiratory tract, from the nose and mouth, through the trachea, through the bronchi, the bronchioles, the respiratory bronchioles, and eventually wind up at these sacs called alveoli. And so the alveoli are the single layer of epithelial tissue. The type 1 alveolar cell is where you're going to see this exchange of O2 and CO2. So as we take air in, that highly oxygenated, higher partial pressure of air is going to drive diffusion from the lungs to the red blood cells. And then the higher concentrations of CO2 and the higher partial pressures from that venous blood that's coming in, that CO2 is going to go from the bloodstream and diffuse into the lungs. But in addition to the type 1 alveolar cells, we also have type 2 alveolar cells, which are going to produce something called surfactant, and we are actually going to discuss here in a little bit the law of LaPlace and why that surfactant is so important when it comes to ventilation. The right ventricle is going to eject venous blood to the lungs, and then that blood will go from the pulmonary trunk to the pulmonary arteries to the pulmonary capillaries, and those capillaries are going to be lined against the alveoli, and that O2 is going to come into the bloodstream, and CO2 will be dumped from the blood to the lungs. And so that right ventricle is going to eject out all of that blood, and that entire cardiac output actually finds its way to the lungs. But despite blood flow being high to the lungs, the blood pressure is actually pretty low within those vessels. So ventilation is breathing. This is the mechanical flow of air in and out of the lungs. And we're going to see that the movement of air is dependent upon differences in pressure. So the few pressures that we're going to talk about here, and the pressures that are going to drive air flow in and out of the lungs, are atmospheric pressure, alveolar pressure, and intrapleural pressure. Before we talk about pressures within the body and of the atmosphere, let's talk about one law of pressure and volume, and this is known as Boyle's law. If we contain gases within a container, right, that is going to have a certain pressure. These particles are going to, collide and create a certain pressure against the walls of this container. So here we see an example of 1 liter of gas leading to 1 atmosphere of pressure. If you decrease the volume of this container, well, then pressure is going to build up, because this is the same amount of gas within this container, but now it has less space, less volume to travel around. So you get more collisions of particles, and this is going to build up pressure on the inside. And so we're going to see, again, that pressure and flow are going to relate to one another. And like I said multiple times, liquids and gases are going to go from areas of high pressure to areas of low pressure. And so when we talk about the lungs, in order to change pressure on the inside, we are going to wind up changing the volume of the lungs. First, let's talk about intrapleural pressure and alveolar pressure. So when I say the pleural pressure, what I'm referring to is this space or this cavity that falls in between the two membranes, the two pleural membranes that we discussed and brought up earlier. The visceral pleura lines the lungs, and the parietal pleura lines the rib cage and covers the upper surface of the diaphragm. And this pleural cavity, it has a pressure, and the pressure is always going to be lower than the alveoli and is always going to be lower than the atmosphere, as long as the lungs aren't punctured. And what this ensures is that the lungs always stay partially inflated with some sort of air inside. If you had a puncture from this pleural cavity, or like a severe puncture wound here, what would happen is those pressure differences would be eliminated, and then that would lead to the collapse of the lungs. So the low intrapleural pressure ensures that the lungs always stay somewhat inflated. But in this pleural cavity is this viscous fluid. And that pleural fluid, what that ensures is that the two membranes stay connected and that they're going to move with one another. And so what we're going to see is that as we breathe, the muscles, the skeletal muscles, the respiratory muscles are going to contract, and in this case the diaphragm is going to go from this dome shape and flatten out and move towards our abdomen. And so as that parietal pleura moves with the diaphragm as it contracts, well, that cavity with that fluid is going to ensure the lungs then move with it. And so what you're seeing is when respiratory muscles contract, the lungs are moving, and then when they relax, the lungs basically just follow the pattern. And so this is eventually going to lead to differences in pressure within the lungs that drive the flow of air in and out. So that difference between the pleural cavity, the intrapleural pressure, and the alveoli, that difference is called transpulmonary pressure, or the pressure across the lung wall. And again, no matter if we're inspiring or we're expiring, inhaling or exhaling, what we're going to see is that pleural pressure is always going to be lower than the alveoli. And again, this just makes sure it prevents lung collapse, and it always will keep a certain amount of air inside of our lungs. When the diaphragm contracts, it's going to lead to lower intrapleural pressures because of the increase in volume of the thoracic cavity, and that gets translated across the lung wall. So as the thoracic cavity expands and the volume of the thoracic cavity increases, the volume of the lungs increase. And what happens is when we increase the volume of the lungs, the pressures inside decrease. The pressure inside of the alveoli is called alveolar pressure. And the movement of air in and out of the body is going to be determined upon the differences between alveolar pressure and atmospheric pressure. And so at sea level, atmospheric pressure is 760 mmHg. 1 atmosphere, it's going to be consistently that pressure no matter what we do at sea level. And so since we cannot change the pressure of the atmosphere at sea level, what we can do is change the pressure inside of our lungs, inside of our alveoli, in order to either drive airflow in or drive airflow out. And so how do we do that? Well, we discussed in Boyle's law that if we change the volume of the lungs, then we are able to change the pressures within. And so when we inhale, the diaphragm again is going to contract, and that's going to help expand our lung volume. And that's going to lower the pressure inside of the alveoli. Once the pressure inside of the alveoli is less than the pressure of the atmosphere, air is going to go from the atmosphere into our respiratory system and then eventually into our alveoli. And so the more we are able to drop that pressure inside, the more airflow is going to come in from the atmosphere. And so we'll inhale that air, we'll take in the O2, and then our lungs are going to start to have CO2 dumped from the bloodstream into these alveoli. And then once we exhale, what's going to happen is that the diaphragm relaxes, and once it comes back up, it's going to decrease the volume of our lungs. And since volume of the lungs is decreasing, the pressure inside and the alveolar pressure will then increase. And then once alveolar pressure exceeds atmospheric pressure, that is going to drive the flow of air from higher pressure to lower pressure, and that's how we're able to exhale out. So this breathing cycle can be divided into 3 distinct phases. Rest, when there is no movement in and out of the lungs. And if we're talking about pressure, that means that the pressure within the lungs is the same as the pressure of the atmosphere. When we inhale, we bring air into the lungs from the atmosphere, and that again is when the pressure inside the alveoli is less than the atmosphere. And then we're going to exhale when the pressure inside of the alveoli is greater than the atmosphere. And that allows us to exhale out air with that CO2 that we are getting rid of. Inspiratory muscles are responsible for increasing the volume of the thoracic cavity and thus increasing the volume of the lungs, which helps drop alveolar pressure and helps drive airflow in. Most of this at rest is done by the diaphragm. As you can see, the diaphragm is this domed shaped muscle, and when it contracts, it helps to expand the thoracic cavity, decreasing pressures in the intrapleural space and in the alveoli. There are also other muscles which help in this role. At rest, the external intercostals help to some degree to help expand the rib cage and again increase the thoracic cavity volume. And then during more active or effortful breathing, we have other skeletal muscles, including the sternocleidomastoids and scalenes, which help pull up on the collarbone, again, and assist in this increase in size of our chest cavity, and thus drop the pressures within the lung. Exhaling or expiration is going to occur once those inspiratory muscles relax. During quiet breathing, that diaphragm relaxing is going to return to that dome shape, and that decreases the volume, both of the thoracic and the lungs, increasing the pressure within the alveoli. But if we are actively breathing, or exercising, let's say, if we're doing an intense activity, there are other muscles which can help in this exhaling, including the muscles of the abdominals, the rectus femoris, the obliques, the transverse abdominis, and then also the internal intercostals will also assist in expiration when needed. This is one last figure just to help understand ventilation. When we are quietly breathing, the diaphragm and external intercostals will contract. This helps increase the thoracic cavity volume. That gets translated to the lung, and it also expands and increases its volume. That leads to a decrease in pressure of the alveoli. And once that alveolar pressure is less than atmospheric pressure, the air will go from the atmosphere into the lungs. And so once we take in that air, gas is exchanged, and then the diaphragm will relax. And, that will cause a decrease in thoracic cavity size. The lungs will recoil and they'll decrease in volume, and that helps build up pressures inside. Once alveolar pressure exceeds atmospheric pressure, air goes from the inside of the lungs out into the atmosphere. There are different things that can impact ventilation. One is going to be surface tension of alveolar fluid. 2 is going to be the compliance of the lungs. And 3 is going to be airway resistance. Surface tension of the alveoli is going to be caused by this thin film of alveolar fluid, which lines the inside of the alveolar cells. And this can actually be reduced by something called surfactant, which we brought up earlier, which is released by the type 2 alveolar cells. And so how this helps with ventilation can be explained by what's called the law of LaPlace. To summarize the law of LaPlace, the pressures inside alveoli are going to be determined by their radius and their surface tension. So in this example here, we have 2 alveoli, and the alveoli are different sizes with the same surface tension. Okay, and so because alveoli B is twice the radius and twice the size of alveoli A, we just discussed how that is going to mean that there will be a decrease in pressure in this alveoli. And since the pressure is lower within this alveoli, all of the air is going to want to travel to this alveoli. And that would mean that this alveoli here would collapse. But that surfactant that is secreted by type 2 alveolar cells will help to lower the surface tension within this alveoli. And so despite the fact that these are 2 different size alveoli, surfactant will reduce the surface tension, and that will help reduce the pressure within this alveoli. And then by doing that, we have a more optimal environment where the pressures of these 2 different size alveoli are now more the same. And so when the lungs fill up with air, it will be distributed all across these alveoli and prevent collapsing in certain areas of the lung. We discussed compliance when it came to blood vessels, but the lungs being this elastic structure that takes in air, volumes of air, it is going to have compliance itself. And so young, healthy adults and children with elastic lungs are going to have a high compliance. And so this means that it's going to be relatively easier for those lungs to expand and stretch out and recoil. And this is going to lead to good flow of air in and out. But in certain conditions and certain diseases, what you are going to see is less elasticity of those lungs and lower compliances, which means that it's going to be more difficult for those lungs to expand. Just like blood flow, airflow can encounter resistances. And what we are going to see is that the size of our bronchioles, just like the size of our blood vessels, are going to determine the amount of resistance. And so when bronchiole size is increased, when the bronchioles are dilated, this decreases resistance and thus increases airflow. But if bronchioles are constricted, this will then increase resistance and thus decrease airflow. So many people that have constricted bronchioles will often be put on a medication called a bronchodilator. And what that's going to do is dilate those air pathways, and that's going to help them take in air and lower resistances within those bronchioles. Here we can see different conditions which impact compliance and resistance. In the case of pneumonia, this is an inflammatory disease where we have a lot of inflammation around our lungs, and this is going to lead to a decreased compliance. And because of that, this is going to decrease the tidal volume, or the amount of air moving in and out of the lungs. We also have what's called restrictive diseases, such as asthma or COPD. And in this case, whether it be inflammation, or other factors, we're going to have an increase in resistance, a constriction of those bronchioles. And so what that is going to lead to a decreased ability for us to exhale out air. And so that's going to impact our blood gases and can ultimately be negative if those conditions are severe enough. So again, a lot of times for certain conditions, people have to be placed on different therapies or medications in order to help with the exchange of air in and out of the lungs. The size of our bronchioles are going to be determined by our autonomic nervous system. And so when we are in an event like exercise, that release of epinephrine and norepinephrine is going to cause our bronchioles to relax and making them dilate, which helps to increase the amount of air and oxygen coming in to prepare us for that fight or flight response. In this case, exercise, we're going to need that increase in airflow to increase the amount of oxygen for our ATP metabolism. During rest, we don't need as much ATP being created. We don't need to dump off as much CO2 out into the atmosphere. We don't need to inhale as much air. So that parasympathetic division is going to cause bronchoconstriction, which increases the resistance and decreases the airflow within our respiratory system. We want to match the amount of air coming in with a certain amount of blood flow, because that is our ultimate goal, not only to get air in through this ventilation, but to match blood flow so we could get the transportation of oxygen from the lungs to the blood out to the rest of the body. So an optimal gas exchange is a ratio of 1:1, meaning that ventilation is similar to perfusion as far as liters per minute is concerned. But what we see in the lungs is that it is not this ideal ratio all the way across. In the upper portion of our lungs, the apex, we are going to see high ventilation to perfusion ratios. We're going to see high amounts of air and lower amounts of blood flow, which create a little bit of a mismatch. And then at the base, we see lower ventilation perfusion ratios with high amount of blood flow and lower amounts of ventilation as far as ratio is concerned. Right here in the middle, we see more of that 1:1 ratio, but ultimately the size of our bronchioles and the amount of blood flow coming to the lungs is going to determine this ventilation to perfusion ratio. And our bodies are better able to match ventilation to perfusion by controlling the size, both of the bronchioles and our blood pathways. And so whether it be through bronchoconstriction, bronchiodilation, vasoconstriction, vasodilation, there can be adjustments to the lungs and to these blood pathways in order to now balance ventilation with perfusion. There are clusters of neurons within our brainstem, within our medulla, and our pons known as respiratory centers. We have what's called the medullary respiratory center and then the pontine respiratory center. The pontine respiratory center is going to be responsible for generating the rate of our breathing and also helping to generate the pattern of our breathing. It's going to receive signals from different areas of the body in order to generate that pattern. It could also communicate with the medullary respiratory center, which is going to be responsible for sending messages out to our respiratory muscles to either signal inhaling or exhaling. The dorsal respiratory group is going to be a group of neurons which helps regulate our breathing at rest. And so when we have normal quiet breathing, what's going to happen is that these groups of neurons are active, and that's going to lead to contraction of the diaphragm and the external intercostals, which lead to inhalation. They then decrease their signaling, and the diaphragm relaxes, which causes exhalation. And so when we have then active breathing, more forceful breathing, This same group of neurons is going to be involved in the contraction of the diaphragm and external intercostals, but it's also going to help activate the ventral respiratory group, which is more involved on this forceful breathing. When the ventral respiratory group is activated and these inspiratory neurons are sending signals, that's going to help with the contraction of other respiratory muscles, including the sternocleidomastoid and the scalenes, which help lift up the clavicle and expand the rib cage, and it's going to help take more air in. The ventral respiratory group also has a division for expiratory neurons, which are going to send signals for muscles of the abdominals and the internal intercostals to contract, and that leads to forceful expiration. These respiratory centers can be influenced by other areas of the brain, can be influenced by the levels of blood gases such as O2 and CO2, and the level of blood pH that's picked up by chemoreceptors. It can be influenced by the stretch reflexes of our air pathways of our lungs. And then there are other things that could also impact these respiratory centers, just as if you were to be hysterically crying or hysterically laughing. That would influence the rate of breathing, temperature, pain, all these different stimuli can ultimately impact the pattern of breathing, the rate of breathing, and the depth of breathing. Chemoreceptors are going to pick up on levels of blood oxygen, blood CO2, and blood pH. We have two main groups of chemoreceptors. They are called the peripheral and the central chemoreceptors. The central chemoreceptors are located within the medulla, and they are going to pick up on levels of CO2 and pH, and going to be our primary driver for ventilation. The peripheral chemoreceptors located in the carotid artery and the aorta are going to pick up on levels of CO2, of blood CO2, blood pH, and blood O2. And so what happens is when we get an increase in CO2 within the blood, there is going to then be a drive to say, hey, let's get rid of this excess CO2. And in order to do that, we need to increase ventilation. So this is a negative feedback loop you're seeing occurring. We're going to see an increase in blood CO2. The chemoreceptors will pick up on this, sending increased input to the respiratory center within the brainstem, and that will lead to more contractions or more forceful contractions of these respiratory muscles. And in turn, what's that going to do? It helps drive ventilation, it helps decrease the amount of blood CO2, and helps increase the amount of blood O2. When we exercise, we are going to need an increase in metabolism. Our skeletal muscles, our cardiac muscles are working harder. And so in order to then supply the ATP needed for these contractions in this activity, we're going to need to increase the amount of air coming in to the respiratory system. And so we're going to see greater contractions of these respiratory muscles. And we're also going to see an increase in blood flow to the lungs. And so this helps to match that perfusion and ventilation ratio, which allows for more oxygen diffusion into the blood. And then we can use that oxygen in order to create more ATP and to create more contractions of our heart and our skeletal muscles. That is the conclusion of part 1 for the respiratory system. Today we talked all about the air pathways and our lungs and how our body adjusts the differences in pressure and volume in order to dictate airflow. And this process, this ventilation process, allows us to take in oxygen and exhale out CO2. In the next video, we'll talk more about lung volumes and capacities and talk more about what normal volumes of air are moving in and out of the lungs. And then we'll also discuss a little bit more about the movement of oxygen and CO2 across the body. Thank you guys so much, and I will see you next video.